for coming. This session is not a very structured session at all. It is a session with your presidents, and so it is me, Cathy Collins-Fulea, is your president. You know that I am your president for currently, and Cathy Collins-Fulea will become your new president. She's the president-elect right now at the end of May, and then Carol Howe. Carol, are you here as well? I think she will be here. She is your vice president. And you know that ACNM has been trying to respond with resources for our members with our website and our COVID resources, also with our the webinars that we've been doing. I don't know if you've been able to join any of the webinars that we've been doing. But we've had several of them on, dealing with this COVID epidemic. I don't know about all of you, but I'm quite sure many of you feel the same way I do, that every day you get up and it's something new, and what is it that we're dealing with, and how are we going to deal with it in our professional lives and in our personal lives. And I felt it would be nice for us to have a sharing session where we talked about some of your needs. Are there different educational things we can do for you? Are there any questions we can answer as the stimulus packages come out, and the different topics next week? For example, we're doing a session on telehealth. We have midwives starting telehealth almost overnight for doing prenatal and postnatal care through telehealth visits and women's health care, just women's health visits. And so we wanted to really hear directly from you. I hope this is more of a listening session on how are things going for you? Is there anything ACNM can do for you more? And a sharing session on and how we can be helpful to each other during this unprecedented time. I know the stress on our frontline midwives who are out there caring for pregnant women everywhere, and just knowing the increased risk for our pregnant women, as well as just health for people. Caring for doing wellness visits as well. So I just want to know how you're doing, and I want to know what are the topics that you want to discuss, and just here to share and be helpful to each other during this really difficult time. Do I have anybody who would like to start? Nobody? Everybody's doing great. I don't mean to be flippant. Don't think that I do. I know this is, I'm worried about our midwives emotionally as well. This is a very difficult time for you. I don't know if you've had the opportunity to deal with your own emotions around this. I was privileged to attend a session around the psych mental health issues with dealing with COVID and the stresses. And I did one thing that really helped me was the concept of catastrophic thinking. And so catastrophic thinking is when you sit and think about all the things that could happen if this goes badly. And how you could spiral yourself down into, everybody has COVID, and you see where I'm going with this. And so this recommendation was, when you do start to do catastrophic thinking, that you stop and pull yourself back and remind yourself about what you can do right now, right today, right in your own circumstance. And I felt like that has been good for me right now as a strategy that I found myself going back to several times a day. as I try to think about all the things, either with ACNM, with our midwives, with the school that I work with our students, with our families, in just trying to do some mental health for myself. And have any of you done any of that for yourselves or been thinking along those lines?
Oh, I'm going to jump in. This is Heather Maurer, ACME's Executive Director for another 12 hours. But one of the things that I've noticed are the days that I go and do a walk, I am so much better than the days that I don't. And we had some pretty bad rain here for a couple of days and I didn't go out and use the excuse of rain, but I have learned by not going out and not getting fresh air and not, you know, I usually am used to commuting and I stop off for my coffee in the morning and chat with friends at work and, you know, that sort of thing. So that interaction is not there and it feels rather isolating, even though I have a safe, wonderful home and my husband's here and my daughter. But I've been going out and what I do is I'll bring my phone, I'll chat with a friend, I'll check in on my parents, I'll listen to music, I'll listen to a podcast, something like that, just to help shift my mind. And I'm also limiting the news. I've been obsessed with watching the numbers and I've stopped looking because it doesn't matter at this point. I mean, my heart, I guess there's a part of me, and I'm sure most of the people on this call feel this as well. I mean, you're midwives, or you're in the healthcare profession of some sort or connected to this work. And so my heart goes out to everyone on the front line. I mean, I have family members. My sister-in-law is a charge nurse, is in charge of the COVID floor. And so I'm a nervous wreck, but I can't be like that. So I'm just sending her love, sending her protection from Virginia. She's in Colorado, and just trusting. And I think that's a big part of it. So I'll just start that. Someone else can jump in and add.
Hello? A little bit.
Okay.
Your microphone, we can't hear you very well. It's muffled. Say who it is that's trying to speak.
They might be on another call. I think if you're not speaking, maybe mute might help.
Yes. Yes. Thank you for that.
You're Corwood Care?
Yeah, they're in a different call.
Oh, okay. Well, no, we're working with you.
Doesn't this happen, right? Everybody, if you can mute, if you're not speaking, that will be helpful.
But I did not expect to hear her. I can try to speak over her. It's Karline here, and
thank you, Karline. Thank you.
I found that prayer really helps. Just digging in with my faith and trying to get something from that wellspring. And usually I would sing and I would pray and I would sing and I would walk. And I've been chained to the computer for the last 2 days with just so many meetings. I'm all zoomed out, I'll tell you.
I know, right? I agree. I agree.
So thank you for that, that encouragement, Heather. I'm going to get out of here this evening. I'm going to go outside. We have a lot of students who are in very difficult straits right now. They don't have adequate Wi-Fi to even connect and engage online to do their exams, their assignments, to get social support, and trying to figure out how to taxi, Wi-Fi sticks to them, and how to find out those who don't necessarily have a strong voice and don't know how to advocate for themselves. So it's been a challenging time revamping our curriculum, our entire curriculum, so that the next 2 cohorts graduate maybe 1 term later rather than months and months later. And so it has been stressful. I've also been looking after my husband, who most likely was exposed when he attended a funeral. We were together most of the time until I returned back home, and he spent another 3 days to visit a funeral that had less than 20 people, but I doubt that they were really practicing social distancing as well as they should have. And he was he's been very ill. So for the last 6 days, we've had no sleep. He coughs all night long. I've been using everything in my arsenal in Western and Eastern medicine, and he's finally feeling better. So at 67 years old, he's got an amazing immune system, and I'm just very, very grateful. But I'm really praying for my cousins who are on the front lines in New York, in ICU, in the dialysis unit, and watching people die in their arms, and having to, you know, protect themselves and the family when they get home. So I feel it for those who are still out there practicing. I'm not practicing at the moment. I'm teaching and doing administrative work and research, and I just, my heart goes out to everyone who is on the front lines.
Karline, where are your students? Are your students?
They're in Ontario right now. So
in
I'm
Ontario, okay.
teaching at Ryerson University, and 3/4 of our program is delivered online, and at the same time while they're having their placements. So this was extremely disruptive. Some of them we could find alternatives with simulations, and they were ahead of the game and had achieved all the benchmark competencies, but others were sort of on the cusp, and we had to, you know, extend their placement to some indefinite time. So it's interesting. Creativity, well, yeah.
Thank you for doing that work. We need more midwives. We do need more midwives.
Yeah.
Anybody else?
Ladies, I'm gonna unlock the meeting for about a minute or two to get Sherry in, so let's hope this doesn't go over.
Well,
Go
I
ahead,
have a question.
continue.
If I don't see a thing to raise your hand, so I'm just speaking up. But I wondered how people who were working in clinical sites, who are preceptors to students, what is the impact on the students? Not just their online training, but their actual ability to be in a clinical setting. Is that these limits on how many people are with maternity care patients? Is that impacting students a great deal?
Well, I can speak to that some, since they do have a lot of students at Frontier Nursing University. We have about 450 students in clinical, and about 200 of the sites were closed to them. Most of the ones that closed quickly were the ones who are large systems. Kaiser, those big systems, and some of the smaller sites did continue to allow the students to go. And you have students who have children themselves who are trying to deal with this with their families themselves, and needed to, you know, they need to deal with their own personal issues. So at this point, we have about half of our students back in clinical and persisting, and about half the students are on academic hiatus, the clinical students.
This
I don't
is
know,
Carol.
anybody else?
I think this is Carol. I think part of it, in the larger systems in particular, is that they don't have enough protective equipment, and they're not going to
twist niggers, heads off niggers, fucking
thing is that I think that some places are restricted because they don't have sufficient protective gear to give to a student.
That's right. Yes. Yes, that is certainly was said as a big issue, is the lack of personal protective equipment. And we see through the news report that there's millions of things being infused into the system. What I haven't heard back is from the system yet. Like, are you guys getting more personal protective equipment? No.
Hello?
Katie says no. Yeah, that is such a huge problem. You know, this afternoon, I got a new article from the Green Journal that's going to be coming out, but it's kind of a article, and it said that we should be wearing personal protective equipment for all patient encounters for maternity care, because our women are at greater risk, and pregnant women are at greater risk, and that it shouldn't only be even during the birth. And so we are talking about looking at that more too, in terms of personal protective equipment. And we've been asked, what is ACNM's stance? Well, you know, the discussions that go on, I don't know if any of you are subscribed to, I'm sure some of you are, the MCDG listserv, which is a Canadian listserv that discusses all kinds of issues on maternity care. And there was a long discussion about it, what people who are doing home births are doing, or people in Canada are doing, people in the United States are doing. And yet, you know, at the end of the day, all midwives should have full personal protective equipment, at the very least for the birth. It doesn't really matter if it's in a home or in a hospital or in a birthing center. And these new recommendations are asking for even more during second stage. And so I'm wondering, how are you all doing with that? And we have been doing some work along with other organizations to try to call for more personal protective equipment of the federal government, and working hard on that. I know that Amy Cole and her team have been signing on with statements that are getting the government to turn. You've seen some of these companies that make paper products are turning to making personal protective equipment, even though they've never done that before. I keep hoping that it's going to hit the front line soon, but I'm wondering, how are you guys handling that?
University is now trying to print with their 3D printers visors. And initially they were just DIY visors, but I think worldwide people are trying to improve them so that they're really level 3 grade, hospital grade, and they cover more and they are reusable. So I've noticed that trend. Also, we had, I think, one of our clients as a gift to thank her midwives, purchased 100 isolation gowns.
Wow.
for the practice. So there's some grassroots work going on where it's just, you know, cloth covers, but I guess they're looking for more of the water repellent, more isolation grade gowns. But we've got to get hundreds of sewists to volunteer or get some grants to pay for them to do this work, because it is a lot of work and it's on an assembly line basis.
And where is that happening?
It's sort of an underground movement. I see posts on blogs all over the place. You know, some of the companies are, you know, changing their way of doing things so that they're following CDC, and I think some are not. So it's hard to know who is and who isn't, and which pattern to use and which material to use. But as soon as I find out, I can post it on one of our information websites, because apparently the CDC has and WHO has specific requirements if it's going to be reusable.
Reusable in a safe way certainly would be helpful, wouldn't it?
Yeah, like a lot of the paper, they can't be laundered, so it has to really be hospital grade type of, you know, the kind we use in the OR, really.
Yeah, yeah. Anybody else? How are you doing with personal protective equipment? Do you have enough? I can see Katie over there nodding no. How is it impacting you?
So I know at our hospital, I don't qualify for a mask. We have very specific requirements that you have to meet in order to qualify for even a surgical mask. It just so happens that I have 2 boxes of my own. I don't usually do a flu shot, and so I've always provided my own. So I happen to have some, but it's just, you know, and I do hospital-based birth in a tertiary care center in my county. So
when are you allowed to use personal protective equipment?
I'm only allowed to use what's standard put on our delivery table, which is a gown and gloves.
You do births without a mask on?
That's what they're requiring of us now.
Oh my goodness.
I don't
Are
because
they
I have
requiring
them.
that because they have a shortage?
Yes.
Or are they because of a shortage?
Yes.
So they're just asking you to provide your own. They're not preventing you from wearing it, right? You just
Correct.
provide your own.
But
if you don't have it, wow. Yeah, I think some of these stories are worth telling and worth hearing in our fight to get more personal protective equipment. I was told by my daughter-in-law, who's a nurse, that she was not allowed to use personal protective equipment for a person under investigation, only someone who tests positive. Just horrendous stories going on out there that are putting our healthcare, nurses and midwives at risk. Anybody else? Honestly, we use these stories. Liana?
Yeah, hi Susan.
Hi.
I'm a Frontier alumni, so it's nice to see you again.
Nice to see you too.
I am in a different situation. I have a home birth practice, but I took a leave of absence for a few years. And so just personally, I've been trying to get back into the workforce for the past 3 years and have not been able to get even a hospital clinic job or an inpatient job anywhere because of not having the number of births, the volume of births necessary for privileging. And then when I look into getting just refreshing my skills for my own sake, mainly it's suturing experience that I need, and I have connections at hospitals and clinics and some birth centers, some personal connections, but at the hospitals where it's the high volume that I would need to ramp up really quickly right now, since I'm not a student and I don't have malpractice insurance under a program, a fellowship program, I'm running into difficulties there. So I wondered if either during this time or maybe perhaps later, if something could be opened up either through ACNM or through Frontier, through schools, where it's a kind of a fellowship program, so that we can get some refresher experience in the hospital setting.
Liana, there are some options, and you can connect with me offline about this topic, okay, and I will talk to you about that. Right. If you don't mind. I would like to go back to this because honestly, I do think this. Let's write to NPR. I want to know more about nurse midwives who are not being allowed. I don't mean to, and I know your issue is important, Liliana, and I will talk to you offline. But I honestly think that this is worth a story on NPR, and I think somebody would do it. This is ridiculous, what's going on. And do you have any other stories that I could, about this personal protective equipment issue?
Are there any stories of midwives who've been infected?
We know there are midwives who are positive. We just don't know how they contracted it, whether it was at a birth or in the community.
Right. So,
Sue, this is Martha. One question, and there's no real guidance on this, is let's say we are working a shift at the hospital.
Yeah.
We come home and we have our clothes on. How do we re-engage into our houses? What is the best way to, I mean, we still live with our families, and how do we protect our families? And there's no real guidelines on any of this out there on if you're a healthcare provider on the front line, how do you, I mean, do you have to totally separate yourself from your family? What, you know, if we don't really have a lot of guidance on that.
Yes, I can see, you know, I see down in Hayden, Kentucky, them putting a plan in place for the surge. You know, everybody has to have a surge plan. I'm sure you're familiar with it. So the expectation is there's going to be a surge in admissions in the hospitals. And so that little hospital down there is actually asking to use some of our housing down in Hayden. And I think that is some of the kinds of things. But I think that is if you're caring for a patient who is positive. And, you know, again, on the MCDG, the site talking about this, many people are doing many things like taking off all clothes in the garage, putting them directly in the washing machine, going right into the shower. And of course, that doesn't help if you're infected and you don't know it. You know, the lack of testing has been such a struggle. And if we really did, you know, they talk about on the news, like, oh, we're going to have a 15-minute test. And how many of you are getting tests back in any closer than 2 days now? Are you starting to get tests back? No. I found that most of the people I talk to are anywhere from 2 to 6 days to get a test back. And so, Martha, I don't know the answer to that question because, of course, it would be different if we knew who was infected. I think these are some of the struggles that we're going through in terms of ethical dilemmas and practical dilemmas. They cross each other. So, you know, I think that's the best guidance that we've seen out there is that is to, you know, we've seen the studies. There is a study that shows that it's 48 hours on cardboard, 72 hours on plastic. I don't think that study talked about clothing, but that came out last week. We know that that it does live on inert surfaces for a while. So I think that is the best that you can do. And it probably, you know, what we keep seeing is the more we know about where you are. So if you, Martha, are in New York, right? So not New York City, but still the incidence is quite high. And so you might deal with it differently than somebody who's in North Dakota where the incidence is very low. You know, we don't have good answers.
Well, this is also an issue that I've heard about, especially with my students. Again, we're in upstate New York, so which is a super hot spot. But all of these little communities up in northern Vermont, New Hampshire, anybody that owns a little place on the lake is all of a sudden dispersing quickly, or in the Catskills or Adirondacks, are going up and staying there. These little small community hospitals that are up in those areas do not have the ability for if these people get sick, and or nursing staff to support that in those small hospitals.
Yes, I know. I know. So what, you know, what Martha's saying is all those people in New York City who have summer homes in upstate are going upstate, and they're all, you know, they're going to disperse it. I also heard from midwives in New Hampshire and Connecticut where they're getting an influx of women from New York City who are coming up to those states to have their babies. And yes, I don't think we have many answers except we can fight for PPE though. Honestly, I think that is one thing that we absolutely could do even more so. I know that, is Amy here? We have done a few things in signing on with other large organizations to try to push the issue of assuring PPE, but I don't think President Trump understands when he stands up there and says, we gave you 1 million masks, isn't that enough? I'm like, oh, geez.
This is Heather Maurer. I just want to also jump in. So my brother-in-law is a congressman, and one of the things that he's proposing in this next package that'll be coming out is testing for everybody, as well as providing people with documentation that they've had the virus and they have confirmation. And this whole process of repeat testing, very much like South Korea or China or some of the other Asian models. So there is movement at the federal side to shift things. Obviously, it's not going to happen in time or fast enough, but it is something that they're looking at and they're going to fight for in this next round of legislation to help. So that's something just to keep your eyes out for.
Thanks, Heather. I think one of the things is getting those, it's like translational research sits on a shelf, like, yeah, it's there, but how do we get it to the people that need it? That's some of our biggest challenges. What else is going on? Any of you, some of the ethical dilemmas that we have been dealing with are the issue of no support person in labor. And you know that has been a very difficult topic, and we have, lots of data well, we have data ourselves, but also World Health Organization's recommendation is that every person should have at least one support person in labor. Our recommendations from, or not ours, but ACOG is saying that if the mothers, if there's any symptoms that they should not have a support person in labor. I may be misquoting that. I may be crossing that over with the taking the baby away from the mother, but I'll talk about that in a minute. But there's been a lot of statements that's about this issue about separating the support person. And as I've talked to members across the last 7 days, the members are not even totally in agreement on this issue. And I've had midwives say to me, I can't believe I'm saying this, but there have been some cases where a support person has been positive. And I think some midwives and some healthcare workers are feeling very threatened by it. It was even said that one person who knew they were probably sick with COVID masked it by taking Tylenol and, to drop the fever and make sure that, so that they could go in to be with a person in labor. I don't know how often that's happening. We know what the data shows us when you have a support person and how much better the outcomes are that you have a support person. And I worry about the issues of collateral damage, like is the cure worse than, and by that I mean, when we say that don't worry, we'll support her, don't bring a support person in, whoever's in the hospital will support her, and the hospital is so stressed, how do they really be able to have one person that can stay with that woman? And will that increase the traffic in and out of the room? And will that put that woman more at risk than if she had one stable person with her? And I know there's lots of opinions around this, and people who have been dealing with the sicker population or the higher incidence have been conflicted about this. And I wondered what your thoughts were about this issue. If any of you had any thoughts along that issue.
This is Beth Cooper. I just want, sorry, Kathy.
I was just going to highlight the comment in the box from Karline. Did you see that? She says home versus hospital birth, water birth versus land birth. Do we abandon mother if she declines recommendations? Is doula a support person, especially if they act as a cultural broker? Do support people have to mask and gown? I mean, that a lot of the issues that you touched on, Sue, she's kind of pulling them on all together. And I think the point is we don't have the answers.
Yes, I wonder, thank you. And thank you, Karline. Go ahead, Beth.
This is Beth. I just wanted to say that this incident that happened in Rochester at our hospital, at Strong Memorial Hospital, made the national news, I understand, made it to the national newspapers, picked up by USA Today or somebody. And
what happened? I didn't hear about it.
Well, that is a case in which the partner denied anything, even though he had well, I don't think they were taking temperatures every 12 hours, but now they're going to take temperatures every 12 hours on the support people. And then as soon as the person delivered, both he and the patient started to have symptoms. And so the staff were not masked or anything else like that. And so it's unknown how many people he possibly contaminated over the course of her labor, or she, and she's still in the hospital. But they haven't, there was a little quick knee jerk. They were about to pull it back, and then Eva Pressman is wonderful, and she just said, no, we're gonna just do more aggressive screening. And one of the doctors suggested adding a lie detector to the exam when the doctor comes in. I think that was tongue in cheek, but that's about the way it starts to feel. At any rate, I will just say I'm gonna have to go off for another meeting actually about this same topic, but for this Rochester area. I just wanna say that we do have a group convened that includes doulas, childbirth educators, family practice docs, midwives, to try to do something in Rochester, because we have this increasing risk, and we have a lot of women who live particularly in the inner city in Rochester, who have relatives in New York City and who are coming up to stay with their relatives to have their babies here. And we have another large group who want to have their babies at home unassisted. And so we're trying to find something, and we're working with the county health department director, and hopefully we can get the two hospital systems talking to each other and working collaboratively. That, if that happens, I'll probably die of shock. But at any rate, we are trying to possibly turn the midwife clinic into a birth center temporarily. So I just wanted to
that's a great idea.
Sort of update of what we're trying to do. Helene Thompson's guy is very active in this, and called me in to get into the group. So
that is a great idea. I did hear.
I volunteered to go work, but I was too old.
I know, right?
Sue, I'd like to hear, is anybody doing home births on the call and what their thoughts are, because I'd seen something written about the home birth midwives being even more concerned about their safety because of you're in a house that you can't control the number of people that are there, or you're there for an extended amount of time. You have to sit, you have to eat. There's a whole different set of issues.
Yes, I did hear even in Canada, they were trying to stop doing home births, which it seems so odd. I mean, on the one hand, you'd think it'd be safer to just stay home, right? Everybody's just stay home. But just like you said, Cathy, there are these issues that are really worrying midwives.
Sue, this is Holly.
Hi, Holly.
On this same subject of home birth, I mean, I agree. There's, this sort of confusion about the topic, and back to NPR. So I don't know if anybody heard the NPR discussion about these issues going on. It was a few days ago, and I was buried in work and something else, and I didn't reach out, but they did not interview any midwives. And they interviewed Maureen Phipps from ACOG. And the only part of the interview they used, I'm assuming she said more than this, but basically she said, women should know that your baby is more likely to be neurologically damaged at home.
Oh, geez.
And
boy.
So I agree, we need to get back to NPR and really talk about this. And, my sort of sense, so I'm up in Vermont, and I also volunteered, and also I think I'm being told I'm too old. But whatever we can do to support the midwives that are attending birth at home, and I think there are going to be more people who are going to choose to birth at home, and so that they're not unattended. I really think we should put our heads together on that. So
Holly, I think one of the things that you're talking about with the neurological was that Chernobyl. article where the APGARs must be lower than they really were, therefore the babies must be having seizures, therefore the babies are damaged?
Right, but the it's not well done, and that gets trotted out. So if you have the new Academy of Medicine birth setting data, they certainly are not saying that.
Right, that's what I'm saying, but that's where it's coming from.
I know where it's coming from, but ACOG is saying that.
Right.
And, they're the, sort of big guns versus, we just had this great study, that came out from the academies that should be used. So I don't know, Sue, if you can do anything with ACOG on this in terms of, we need to be, all of us, thinking about how do we connect each other to assist women to have a safe birth wherever they are.
And we're getting lots of calls.
Yes, go ahead, Debbie.
Last minute calls. My baby's due in 3 days and I've just been told nobody can go in with me. And the key is, we have to have their records, because as we talk with other people who, maybe in that practice that they're switching from, without giving any identifiers, they'll say, well, is it the one that we just found out is positive? And without having a chart, we would never know that.
Right.
So it wasn't, but, it's imperative that we get some kind of records.
Yes. So I think this is a good conversation about what we can take out. We did have a conversation with ACOG this week, and Maureen was very open to working together, and we did briefly talk about, they just don't want to talk about home birth. ACOG just does not want to get on that bandwagon, or I can't push them. But you know what, this may be an opportunity, because women are going to have home births. And so period, this may be a good opportunity where we say they are going to have home births. So we need to open up the conversation, and we need to be able to do safe transfers if it's necessary, and not just, put our heads in the sand, which sometimes I feel like that they're doing in terms of home birth. If they can just say, based on not great evidence, that it's not safe, and then this might be an opportunity to turn that conversation. Thank you, Holly, and thank you, Debbie. Kathy. What else is going on? Liana?
Yeah, I'll just speak as a home birth provider. The things that I'm running into as far as not being able to get started taking clients is, like I mentioned, the skills refresher, even if it's a few days at a large volume hospital, and things that would be helpful would be also immediately DEA number, so I can prescribe controlled substances. I think that would be helpful for midwives across the U.S. That's not something that I normally carry as an out-of-hospital provider, but it's very much something that's necessary with the mental health of women, and writing prescriptions. I'm getting requests for prescriptions from across the state, and I'm able to do that for people, but I,
Prescriptions for what?
Oh, well, for anti-anxiety medications, and yeah, just, and then, so the DEA number, the fee waiving that would be very helpful for me as a community provider, and opening up, I know ACNM opened up membership recently, and possibly doing that again. so that I can be part of these conversations, and also so I can get in touch with the local chapter. I was part of helping start our Iowa chapter, but because I've been out of practice and then in the out of hospital setting, I'm one of those who can't afford the membership fees. So I can't even get in touch with my colleagues who are in the Iowa chapter now that I helped start. And then malpractice insurance being another thing that comes to mind when I think about attending births. I'm very happy to attend births again, and I can do it very quickly. Like I said, even just a few days of suturing practice at a hospital, and I'm good to go.
Okay, thank you. What else is going on out there? I think this has been really helpful to hear about some of the struggles. And I do think, I don't know who said it, but we need to do everything that we can to support our midwives who are on the front lines caring for patients. And so anything that we can do to support you, we're there doing the best with doing what we can. I do think some of bringing to some of these issues to the press, and you know, it's always when you have the real stories that it makes the impact. Even more than data, stories make a bigger impact. So if you do have stories to share, I sure would like to hear them.
In Virginia, we're trying to use this opportunity as the governor has been trying to decrease some of the regulatory restraints to allow more practitioners, including everything from med students and nursing students and so forth. So we're trying to use this opportunity to get certified midwives regulated and licensed in our state in Virginia. Not having success so far, but we're pursuing that. Our chapter chair has been working diligently with our lobbyists, with the governor's office and so forth.
Yes, that would be a great help. Holly, are you wanting to speak? No, I have Holly Kennedy raise her hand on my thing, but maybe that was from before. Yes, the importance of getting our CM colleagues to have more states where they're licensed is so important. And I know that's been a big push of ours. And I think we have, from what I heard last, about 5 states in progress. And so that's been most encouraging. We've spent quite a lot of time on that issue and legislatively. Jude, any thoughts about using outpatient surgery centers for low-risk women? I think that somebody else brought this up. I talked to a midwife last night where she said in California, they were putting up a tent hospital in the parking lot, and they were primarily using it for maternity care and as an option. And I think that keeping the women, healthy women, out of that environment is going to be more and more seen. Are any of you seeing any strategies to separate pregnant women from the rest of the hospital population?
Not yet, but it's very interesting. Any laboring person coming in, if you're an induction, you need to come in before 5 because you can go straight to central registration and then go straight up to the unit. But anybody after 5 p.m. has to enter through the ER, and that's not where you want someone in labor to be. So there's big discussion about how are we going to maneuver that and what entranceway can we get them in after 5 p.m. so that they're not walking into, quote unquote, the petri dish per se.
Right.
One other thing I wanted to mention, I know people think, well, you know, I'm older, I'm out of the realm, and I can, you know, I can't be on the ground helping, but there are so many other things that you can do to help. And especially when we're doing all telehealth on so many visits, remember, you're still nurses, you're still midwives that, you know, maybe offer to learn how to maybe do some of that. You can do it from your home if they would be willing, you know, because there's going to be a great number of people that are going to get sick that aren't going to be able to, midwives that are on the front line that aren't going to be able to take over all of the information that we need to.
That's Martha, that's great. One of the things that I volunteered to do, no one's taken me up on it yet, but I think doing postpartum telephone calls would be incredibly helpful to practices and to women. You know, so
we're doing all of our postpartum, 6-week postpartums on telemedicine. So
I'm talking early, in those early few weeks when, you know, the stress is so hard, and, you know, as a support to women might just be an additional thing that would take the stress off the practicing midwives. So just a thought.
Well, that is a good thought. And, you know, as we, you know, that might be something we can do, is get a group of volunteers. And if somebody needs volunteers, we might be able to connect them. That might be something that would be really useful, because we don't want those women coming out. We are having another webinar next week on Wednesday night at 7 to talk about converting to telehealth. And we just have several midwives who have done a quick conversion. Suddenly people are doing telehealth visits. And there's a few that have been doing them for a long time. Cathy Collins told me, for example, Henry Ford. But a lot of them have converted from, in 1 week, suddenly they're doing telehealth visits for prenatal and postnatal care. And so we're going to have a webinar about that next week to kind of see what are the tips and tricks and challenges and solutions.
Lisa Paine, I wanted
to see the question about the annual meeting.
Yes. So I want, from Sherry Sase24, I was wondering, because we've been working on this annual meeting thing for so long, and she says the annual meeting update is ready for communications to members and registrants. It will come out tomorrow, and the meeting will take place virtually. Now, I'm sorry, I missed a comment.
This is Lisa Paine. I wanted to.
Thank you, Lisa.
Chime back in. Yeah, sorry, didn't want to interrupt. I want to go back to a couple of things. One is the that question you were asking, Sue, about having the births in some other setting.
Yes.
Outside. Now, some of you know that I've been sort of annoying in my predictions of where we're going to end up in a couple of weeks, given my Johns Hopkins public health background. But I'm going to give them another one today. And that is that it would be really, really important, I think, that there be guidance from ACNM sooner than later if midwives find themselves in this position of the births happening maybe in a tent outside of the hospital or in a church or in some other location. Because the wave, especially some of the comments about these smaller towns and what's happening with, you know, people moving into those towns that are going to be bringing the virus, there's not going to be any place for those women to be in the hospital. So if that guidance could go together sooner than later, it would be a response to those midwives who absolutely are going to face that. There's going to be no way to avoid it in many, many parts of the country. So my other, I also want to go back to, I'm sorry, I can't remember her name, from Iowa Home Birth, talking about the relevance of membership in ACNM at this point, to be able to connect with colleagues and to be able to best practices information. While we all know that, you know, there's never a really good time to think about doing something drastic, but one possible consideration would be opening membership for a period of time, for a few months, for people to pay whatever they could pay as a part to recruit people back to the organization, but secondly, to give those kinds of resources to folks who who really can't afford to partake. I know it's complicated, but I just wanted to acknowledge what it was she said and what I heard.
Thank you, Lisa.
Mm-hmm.
Other comments or concerns?
I think it's going to be important too in the next couple of weeks. There are so many physicians that are wavering with, you know, do we induce early? Do we do a C-section? You know, so guidance as far as that goes, and research, evidence-based information, which I know is very limited at this point, but I anticipate that that's going to be an area that those of us that are practicing clinically are going to need information and help to support women's decisions.
Thank you, Katie. I have seen quite a bit of research come across that is not supporting C-sections for as a solution for COVID. And so we can put that research together for you. That's a really good one. Thank you. And we will. To the best of our ability. Nobody knows everything about COVID, but to the best of our ability, what we know right now that's coming out is not recommending C-section for COVID patients. As a matter of fact, there were a couple of cases last week that were documented in the literature where they really crashed after a C-section. I'm not saying whether the C-section wasn't necessary, but it could be the tipping point for someone, to have surgery like that. Any other comments? I hope that you have found this somewhat helpful. I just wanted to open a forum where we could talk about issues. I found you guys to be pretty quiet, most of you. And I don't know if it would be useful to do this again, whether you found it helpful or not. But maybe we'll put out a survey, or if there's anybody that wants to put in, just say in the chat box, was this a helpful thing or not very useful? Sometimes I think it's good for people just to come together and talk about, what's going on and what the issues are. And I think we at ACNM have gotten some good information about, what are these big issues. And it's not that we didn't know PPE is an issue, but I think one of the things we could do is a reinforcing statement that midwives do deserve full PPE, not partial PPE, is recommendation from your professional organization at this point in time. And, these issues around where are the babies going to be born. I hear you, Martha, in upstate New York, in these little rural areas, and have grave concerns about all those women moving out of New York City up there. And so, will you end up doing births in clinics next door to the hospital, places, we're going to have to see how that all plays out. But we're here the best that we can do to help. That's what we're trying to do. And we'll do this again, and watch for the other things that are coming out. The telemedicine. As a matter of fact, I would like to have one more telehealth person. If you know anybody who is skilled at doing telehealth for prenatal and postnatal, I'd like to have one more person on that panel. Please send me your recommendations, and we're here for you, and stay in touch with us. Let us know what's going on out there. We're here to help you with these issues to the best of our ability. Have a good evening, everybody. Thank you.
Thank you, Sue.
Thanks.